in lactation and boarding with, lactation and bonding with newborn care. She's taught at ADN nursing students in both the clinical settings and on-site programs. She's a member of Sigma Theta Tau Nursing Honor Society. Welcome.
Thank you. I will share my screen now. Okay. During the DNP program at Duke University, I had the wonderful opportunity to develop a quality improvement project, and I wanted to choose something that was very passionate to me. So that led me to increasing breastfeeding rates in infants and newborns. I always like to start off by sharing why that topic is so passionate for me and express the importance and the need through just a personal experience. So I am a mother. I have a 3- and 4-year-old. And when I was pregnant with my first child, I initiated breastfeeding. However, I was having latching issues. It was very painful, and I was concerned the baby wasn't getting enough milk. The baby was crying and frustrated. As a new mother, I was crying and frustrated. So I went to seek out help. I went to my OBGYN, and they unfortunately didn't have any resources for me. So then I turned to my child's pediatrician. Not only did they not have a lactation consultant in office that could help with me, they didn't have providers that were available and had the time to help me. And when I asked for a referral, they didn't have any information readily available to hand out to me. So I went home, I was very frustrated, and I quit breastfeeding within 3 months. 12 months later, I then had my second child and initiated breastfeeding again. I had the same latching issues, went back to my child's pediatrician. Even though they still didn't have a lactation consultant in office, that time they gave me a list of resources and local lactation consultants in the area. I chose one, and she was able to come out to my home, provide education, hands-on lactation support, and training. And I was able to successfully breastfeed my child throughout the full 12-month period. So with that being said, I realized then that breastfeeding education and lactation support was truly the difference between being able to be successful with breastfeeding. Realizing that not everybody receives this information and support in the traditional clinical settings, such as their pediatric primary care offices, I chose to bring breastfeeding education and lactation support into the community. So I will start off by just discussing the benefits of breastfeeding. So breastfeeding is the best form of nutrition for the infant. It provides passive immunity. It aids in growth and development. It decreases the risk for chronic disease. It decreases asthma by 22% and sudden infant death syndrome by almost 50%. It also benefits the mother as well. It decreases the risk of postpartum depression, decreases the risk for breast cancer. It increases the bond with the baby, decrease healthcare costs, and it's economically advantaged and ready available. And that was especially important during the pandemic when there wasn't a lot of formula on the shelves. In the United States of America, 83.2% of postpartum mothers initiate breastfeeding, but less than 50% exclusively breastfeed throughout the first 3 months. And then less than 25% continue throughout the first 6 months of life. The World Health Organization, the CDC, and the American Academy of Pediatrics all recommend breastfeeding exclusively throughout the first 6 months. And then after that, using a combination of food with breastfeeding throughout the first 12 months. 4 out of 5 women initiate breastfeeding after giving birth, but there's many barriers that prevent them from continuing. Those barriers include lactation support, poor social support, misconceptions about infant formula, the marketing of infant formula, and then other factors include prenatal breastfeeding education, confidence in providing the nutrition, and provider recommendations. One article stated that 30% of mothers reported lack of support from healthcare professionals as a reason they did not initiate breastfeeding. After the initial consult for lactation during hospitalization post-delivery, there's no standardized process to follow up in pediatric primary care that monitors, assesses, or addresses ongoing needs and educational support for the lactation concerns throughout the recommended 6-month time frame. Every pediatric does not offer lactation services on site nor have the information readily available. There's also no standardized process to ensure that parents receive education and resources that they need to be successful with breastfeeding. The Healthy People 2030 target is 42.4% for exclusively breastfeeding. However, from the year 2015 up until 2018, the rate was less than 26%. There are many racial disparities, barriers, and inequalities when it comes to breastfeeding. Non-Hispanic Black women actually have the lowest breastfeeding rates out of all ethnic groups in the US. Breastfeeding is largely influenced by maternity practices and support within the healthcare system. And the research shows that Black women are less likely to receive the support that is needed. A recent study found that supportive breastfeeding practices was less likely to be implemented at birthing facilities in areas where a larger percentage of where Black women live. Black women are also more likely to return to work within a few weeks after giving birth. Parents must depend on childcare, and formula becomes more convenient, which drives low-income women to feel as if they don't have a choice to breastfeed. And the Hispanic Latino mothers that immigrant to the US, the breastfeeding rates are lower. And people with lower social economic status also have lower breastfeeding rates. Native Hawaiian mothers have very low initiation rates, is actually below 65%, and 46% of Native Hawaiian mothers introduce formula after the first week. So the problem on the national level is that there's no standardized process to inform families about breastfeeding ahead of giving birth. At the local level, there's many primary care pediatric facilities that lack in-office lactation services or resources that could aid in increasing knowledge and awareness about breastfeeding to families. And then on the organizational level that I used for my project, they did not currently have a lactation program in place, and they found it also very difficult to engage families after the pandemic. This quality improvement was aimed to evaluate breastfeeding education and lactation support for moms and families offered in a community setting. The purpose of this project is to improve knowledge and confidence in breastfeeding families, as well as increase the identification of lactation concerns through the community-based setting to ultimately raise the exclusively breastfeeding rates in newborns and infants. The first aim is to increase the number of mothers who will intend to exclusively breastfeed until the baby is 6 months old after implementation of an educational-based lactation course. The second aim is to increase the confidence and knowledge in moms who intend to breastfeed after implementation of the lactation course. And then third is to demonstrate participant satisfaction on the post-survey. Upon conducting a literature review and synthesis, the evidence supports increased education, support, and follow-up, increases breastfeeding rates and education and duration. Educational models that provide lactation support and follow-up have been successful in increasing breastfeeding rates and duration. One study showed that the percentage of mothers exclusively breastfeeding their infants at 6 months was 22.4% in the group that received education through PROLAC interventions and 8.8% in the group that did not receive education. The workshop took place through 6 weekly meetings, and it was 2 hours long. And they provided discussions, learning skills through hands-on breastfeeding practice. And this study actually found that applying breastfeeding education through the PROLAC interventions was more effective than the usual practices in primary care. Families provided with breastfeeding education prior to pregnancy and during pregnancy and after delivery leads to decreased breastfeeding cessation. When women were followed from 34 weeks gestation up until 4 months postpartum, results showed that 43.2% of mothers receive antenatal and postnatal lactation support were exclusively breastfeeding their infant at discharge, in comparison to 30% in the group that did not receive education. At month 4, after delivery, 94.6% of women that received education to breastfeed were breastfeeding on demand, which was higher than those who were in the control group at 75.9%. In another study, breastfeeding counseling was implemented upon discharge in breastfeeding mothers and followed throughout 6 months. Infants were less likely to be readmitted 1 week postnatally in moms from the group that received education. It also showed that 6 months after delivery, infants in the experimental group were breastfed exclusively at a rate of 4% higher than the non-experimental group, and mothers were breastfeeding more frequently. The evidence shows that providing interventions that deliver breastfeeding education, lactation support can significantly increase exclusively breastfeeding rates, duration, and improve confidence in breastfeeding mothers. The research not only supports the desired outcome of the project, but it also showcases the effectiveness of the innovation in influencing breastfeeding rates and confidence. This project was not intended to generate new knowledge, but implemented evidence into a community-based setting to improve breastfeeding rates in infants and newborns. So for the project methods, the design used a pre-post design using validated questionnaires. I used infant feeding intention scale to assess intention, the breastfeeding self-efficacy scale to assess confidence, and then the breastfeeding knowledge, attitude, and confidence scale to assess the knowledge. And then a 5-point Likert scale was used to assess satisfaction with the program. Participants used Sign Up Genius to sign up for the program, and flyers were posted all around the community to advertise the project and the program. So the flyers were placed in hospitals, daycares, libraries, and pediatric offices. A pilot course was planned and implemented, and then upon completion of the pilot course, the committee discussed what went well and what did not, and we made revisions. After revisions, 3 weekly lactation classes were implemented. The setting was the Carr Family YMCA, which consists of almost 7,000 active members, with families and adults with dependents being the largest membership population. The population also included members of the YMCA, but was also open to everyone in the community, and it was offered as a free lactation class. It included 1 pilot class and then 3 60-minute weekly classes in person to provide breastfeeding education, hands-on lactation support, and to identify lactation concerns. So the class included information such as what to expect before, during, and after birth with breastfeeding, health advantages for breastfeeding for mom and baby, baby's first feeding, breastfeeding management, establishing milk supply and maintaining milk supply, positioning and latch, when to seek help, and how to identify the baby's cues. This class, lactation class, was presented through a PowerPoint and consisted of breastfeeding recommendations from the CDC, the American Pediatrics Association, as well as the World Health Organization and other peer-reviewed journal articles. A handout with a list of resources was also given to the participants and included local lactation consultants in the community so that they could reference at a later time or share with friends and family. For sustainability of the project, implementation into future monthly, quarterly classes or during special events is being considered at the Carr Family YMCA. And to sustain the project in the future, we've been discussing about adding it to the regular YMCA programming special. The infant feeding intention scale, also known as the IFI, was used to evaluate for the first aim. This scale is valid in assessing the strengths and intentions to begin breastfeeding and to sustain the process. So the first aim was measured by collecting the data from the post-survey results and comparing them with the pre-survey results from the valid instrument. So this was basically comparing the intention to breastfeed for 6 months before receiving the education and then the intention after having received the information. The second aim was measured by collecting the post-survey results and comparing them with the pre-survey results. That was collected by using the validated instrument, the breastfeeding self-efficacy scale. This compared the confidence moms have in breastfeeding before the class and the confidence after receiving education. And it used a 5-point Likert scale, whereas 5 reflected always confident and 1 reflected not confident at all. The knowledge was assessed by using the 10 questions from the knowledge dimension of the 24-statement breastfeeding knowledge, attitude, and confidence scale, and this used a 4-point Likert scale. The third aim was measured by rating the level of satisfaction with the breastfeeding course using a 5-point Likert scale. To evaluate, a statistician was consulted. The first aim was evaluated by measuring the percentage of mothers who intend to exclusively breastfeed throughout the first 6 months and compared against the scores on the pre-innovation survey prior to their participation. The first aim required a paired t-test, and the data is illustrated on a bar graph. The second aim was evaluated by comparing the before and after scores of the BSES scale, and it also required a paired t-test and is illustrated on a bar graph. And then lastly, the third aim was evaluated using descriptive statistics to calculate the percentage of the satisfaction scores on the post-innovation survey. The project remained compliant with HIPAA throughout the entire project, and the patient's personal health information was protected the entire time and de-identified. So as far as the results, the paired t-test showed statistically significant improvement in the means. The BSES scores, P was less than 0.001. For the IFI scale scores, P was equal to 0.022. And for the BKAC scale scores, P equals 0.018. The mean and the standard deviation is shown in the table below. There was 13 participants overall, and the degree of freedom for each category was 12. The BSES effect size was large, and the BKAC and the IFI scales had a moderate effect size. So this table right over here to the right shows the before and after scores for each survey. So for the first column, the BSES shows the before and after, so there was a lot of improvement there. And then the IFI scale also showed some improvement, and then the BKAC scale showed improvement. All three AIM objectives were met. For the intent to breastfeed in the pre-test average, it was 12.58, and it improved to 14.2 on the post-survey. For the assessment of the confidence, the pre-score average was 30.54, and that improved to 44.23 on the post-course survey. And then for the knowledge dimension, it was 6.69 on the pre-course survey, and that improved to 8.23 on the post-course survey. The most significant improvement was shown in the assessment of confidence, and the findings were both clinically and statistically significant, thus meaning it is applicable to practice. The demographics consisted of 69.2% of the participants were Black or African American. The largest category for marital status was 62% for participants that identified as single. 100% of the participants were female. And then the age group, most of the participants were 35 and over, and that was 40% of the group. And then for education, 38% was the highest category, reporting a master's or doctorate level of education. And then the income statistics was very mixed. In conclusion, The post-course survey scores were higher than the pre-course survey scores in every category. Therefore, increased education support increases the outcomes in breastfeeding intention, knowledge, and confidence, thus increases the intent to initiate and the duration of breastfeeding. 69% of the participants were African American, which also shows effectiveness in providing alternative ways to engage minorities to breastfeed within the community setting. So the future goals upon this project, I would love to become a lactation consultant, offer both virtual and in-home consultations, decrease racial and socioeconomic barriers by empowering minority women with education, confidence, and knowledge, and targeting rural, low-income, or minority populated areas. I plan to continue to offer this free lactation class at the CAR YMCA, and I hope to continue to share this presentation. Here's my contact information. I can be reached at either email, and here is my telephone number. And I would like to thank you for your time today. And here are the references.
I would like to introduce the next two speakers. Tara Spencer is the Deputy Director of the Division of Nursing and Public Health at the Health Resources and Services Administration Bureau of Health Workforce. In this capacity, she provides strategic guidance and oversight for a $642 million a year investment focused on developing and increasing the health workforce through various education and practice programs. Under her leadership, the DNPH's workforce development efforts support the three key areas: nursing education and practice, advanced nursing education, and behavioral and public health, with a focus on increasing the supply, distribution, and preparation of the diverse nursing workforce. Behavioral and public health workforce prepared with a skill set to deliver quality care in community-based settings to rural and underserved populations, and to promote new innovative models of healthcare delivery. Ms. Spencer has a Bachelor's of Science in Nursing from Hampton University, a Master's of Science with a focus in Nursing Leadership and Management from Stevenson University in Maryland. Next, I'd like to introduce Dr. Adanna Agbo, who currently serves as the Chief of the Advanced Nursing Education Branch in the Division of Nursing and Public Health at the Health Resources and Services Administration Bureau of Health Workforce. She is responsible for developing policy recommendations and implementing advanced nursing education programs that train nurses in advanced public health and addressing the issues of supply, access, quality, and distribution of the nursing workforce. She earned a Bachelor's in Nursing from Pittsburgh State University, a Master's in Nursing, a Master's in Public Health, and a postgraduate certificate in Teaching in Health Professions and Global Health from the University of Maryland in Baltimore, a Doctor of Public Health from Morgan State University. She received a Fulbright grant in 2015 that enabled her to conduct a rural community-based study in Nigeria, exploring factors associated with maternal health outcomes, and was recently selected into the prestigious Nurse Leadership Institute at the University of Maryland Baltimore School of Nursing. She is also a current Center for Disease Control and Prevention International Experience and Technical Assistant Fellow. Thank you.
Thank you so much for that wonderful introduction. We are so pleased to be here, and I'm going to share my slides now. Okay. So like I said, good evening again. It is our pleasure to join you today to share an overview of HRSA's nursing workforce training programs that impact DNPs and will be of interest to your work. HRSA's goal is to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. We serve multiple sections of the population. Our HRSA programs focus on serving those most in need. For example, 30 million people in underserved communities were served by HRSA programs. 58 million pregnant women, infants, and children receive support from HRSA programs. 3.6 million infants, which is nearly every infant in America, receives support from our programs at HRSA. More than 576,000 people living with HIV are supported through HRSA programs, and more than 1,800 rural counties and municipalities across the country are impacted by our HRSA programs. In 2024, in fiscal year 2024, our HRSA workforce investments focused on supporting training health workforce. At HRSA, we take actionable steps to achieve health equity, improve public health, ensuring access to care for those in rural and underserved communities, and fostering health workforce and health infrastructure able to address the current and emerging healthcare needs of the nation. These are some of the key goals at HRSA. So in the fiscal year 2024, we gave out scholarships and loan repayments to nearly 24,000 clinicians, which includes nurses and other health professionals to provide healthcare in underserved and rural areas. We funded more than 1,400 medical and dental residents to work and training underserved and rural communities. And we trained about 18,000 more mental health and substance use disorder providers. HRSA is highly invested in strengthening the health workforce, especially by training providers in high-need communities. More than 20,000 clinicians receive scholarships and loan repayments in return for practicing in underserved communities through HRSA's National Health Service Core program, and you'll hear more about that in a few minutes. Over 34,000 individuals from racial, ethnic, and economic backgrounds underrepresented in the healthcare workforce are currently receiving support and training to join the health workforce through our programs. Approximately 13,000 community health workers who reflect the diversity of the communities they serve will be trained and deployed to expand access to community-based care. One of the things I wanted to stop and talk about now is that some of our HRSA's projections show shortages and maldistribution of nursing workforce supply across the United States, and as the need, especially as the need of healthcare grows. Shortages of maldistribution are shown in generalist nursing as well as advanced practice nursing arenas, especially in relation to nurse faculty shortages and the shortage of primary care providers, specifically to the distribution in rural and underserved areas. So because of that, I introduce you to one of HRSA's bureaus and offices, which is the Bureau of Health Workforce, which is where our division is housed. The mission of the Bureau of Health Workforce is to improve the health of the underserved by strengthening the health workforce and connecting skilled providers to communities in need. We do this by supporting education, training, and service. The Bureau of Health Workforce, or BHW for short, is uniquely positioned to address these workforce challenges by supporting community-based training programs that encourage clinicians to work in rural and underserved communities. BHW is helping to grow a skilled health workforce and thereby improve the healthcare of those who are in communities that need it the most. HRSA workforce aims under the Bureau of Health Work focus on 4 key areas: access, distribution, supply, and quality. The BHW key aims focus on these areas to improve the health of people who need it the most. Some of our programs touches more than one of these aims, more than another, but collectively our programs together with our grantees help improve and expand care to the most vulnerable. Through our programs, we focus on access to increase access to quality services, making it easier for people to get the kind of healthcare they need and they deserve. We balance the supply of healthcare workers with the demand for care, and we work to increase supply for future health professionals. We also improve the distribution of the health workforce by encouraging individuals to work in those geographically underserved areas. And ultimately, we strive to improve the quality of that workforce and the care they provide to rural and underserved communities so that we can enhance patient care and safety and also patient outcomes overall. So the Division of Nursing and Public Health, which houses most of our nursing and public health programs. The division consists of 3 branches and administers and provides oversight of nursing, behavioral health, and public health workforce development programs. Our annual budget is over $610 million with about 51 FTEs when fully staffed. Our impact focuses on areas of increasing or expanding academic practice and community partnerships, enhancing curriculums and clinical training to address the needs of communities, and focusing on faculty development and other continuing educational opportunities for both faculty and preceptors. Our 3 branches are the Nursing Education and Practice branch, the Advanced Nursing Education branch, and the Behavioral and Public Health branch. I'll start with introducing you to the Nursing Education and Practice branch. This branch focuses on exactly what the name says, the education and practice of nurses, and has about 8 programs that support the training and practice of nurses. We have the Nursing Education Practice Quality and Retention Registered Nurse Training Program, the NEPQR RNTP. We have the Nurse Education Practice Quality and Retention Simulation Education Program, the NEPQR SET. We have the Nursing Education Practice Quality and Retention Clinical Faculty and Preceptor Academies Program, the NEPQR CFPA. And the Nursing Education Practice Quality and Retention Mobile Health Training Program, the NEPQR MHTP, the NEPQR ICPC BHI, which is a Nursing Education Practice Quality and Retention Interprofessional Collaborative Practice Behavioral Health Integration Program. We have also the Nursing Education Practice Quality and Retention Pathway to Registered Nurses Program, the NEPQR PRNP, and the Community Health Worker Training Program, the CHWTP. And the one area that I know that will be of interest to the DNPs of color, which is the Nursing Workforce Diversity. This is one of the programs in the NEP branch that focuses on training both generalist level nursing students and also advanced practice nursing students, including DNPs. And this program focuses on increasing the diversity of the nursing workforce specifically. In our Advanced Nursing Education branch, which is the branch that will impact mostly those members of the DNPs of color, we have about 6 programs in that branch. We have the Advanced Nursing Education Nurse Practitioner Residency and Fellowship Program, ANE NPRF. We have the ANE SANE, which is the Advanced Nursing Education Sexual Assault Nurse Examiner program. We have the Advanced Nursing Education Workforce, a new program. And we have the Nurse Anesthetist Traineeship Program, NAT. We have the Maternity Care Nursing Workforce Expansion Training Program, the MATCARE program. And last but not least is the Nurse Faculty Loan Program, NFLP. Our programs focus on not only increasing the number of advanced nursing education, but specifically training the next generation primary care providers, in addition to nurse anesthetists, nurse faculty, as well as SANE certified nurses. So looking at numbers for the DNPH program, in FY 2023, these are some of our investments. The Nurse Education Practice and Quality Retention side of the division, we made about 81 awards for a total investment of $55.8 million. In the Advanced Nursing Education side, we had 204 awards for a total investment of $89.1 million. And the NFLP, we made 88 awards for that program for a total of $26.5 million. Our NWD, which is a Nursing Workforce Diversity Program, we made about 43 awards for $22.4 million. And in our Behavior and Public Health branch, we also made some investments. The mental and behavioral health workforce programs, we made 132 awards for that program for a total of $79.4 million. And our BWIT training programs, which is the Behavioral Health Workforce Education and Training Programs, 286 awards of 114.2 million total. And our Public Health Workforce Training Programs, we made 10 awards for $10.4 million. So one of the things we think about within the division is to look at what we focus on as a division in terms of how we support training of new nurses and training of nurses in general. We look at, we focus on certain themes, some of the themes that we focus on, which are from the recommendation literature and what's going on in the field, is to look at the role of nurses in primary care. We also consider diversity and looking at the percentages of diversity of the nursing workforce in general, and how are we then considering this in the programs that we develop. Also, how are these programs including social determinants of health or addressing health equity within their curricula? And also looking at how is the training being done? Are they considering focusing on interprofessional team-based care in education and practice? And are they using innovative models of training and practice, which includes virtual learning, telehealth, teleeducation, and so forth? And also, are they considering academic practice partnerships to bolster nursing education and practice? And then we're looking specifically also at the residency of APRNs. So we have some new and forecasted grant funding opportunities for FY24. The one program that we have that is currently open is the Advanced Nursing Education Sexual Assault Nurse Examiners Training Program. And that one is currently open right now, and we're accepting applications. The Nurse Faculty Loan Program is a program that we announced this year, but it's also already closed. And that one focuses on increasing the number of nurse faculty in the nation, across the nation. We have our opioid impacted family support program that is forecasted to be open soon, sometime this spring. And also the nurse education practice quality and retention program, workforce development program, and NEPQRWD, which is also slated to be announced this year as well. So when we thought about presenting at the DNPs of color, we thought about some of our nursing workforce development trends in terms of how many DNPs we've trained and how many students we've trained overall. So first of all, I want to show you here to look at just overall our nursing workforce development programs, the numbers that we produce. So in academic year 2019 to 2020, you can see that we trained a total of about 24,000 nurses, and with about 10,000 of graduates that year, producing about 10,000 graduates. In 2020 to 2021, we increased those numbers to 28,000 plus and about 12,000 graduates. We saw an increase as well in 2021 to 2022 with 31,000 trained approximately, and 12,000, closer to 13,000 graduated. But then we saw a dip, right? If you think about the aftermath of COVID, we saw this dip of 23,000 trained in 2022 to 2023 and 10,000 graduated. Then when we look at DNP specifically, you can see here that in our new program, our NAT program, NFLP program, and our NWD program, we are graduating DNPs, and we're training DNPs as well. So if you can look here, focus on the light blue bar, the light blue bar for our new program. We trained about 1,000 in the year 2022 to 2023. We trained about 1,000 DNPs and about 85 DNP MPH graduates and 382 DNP graduates, and so on and so forth. You can see the same trend in our NAT program as well as our NFLP. We had more DNPs trained and graduated, trained in the NFLP program, but more graduated in the NAT. And we see that with the NAT program because most of the NAT programs now, training programs across the nation, are now going to a doctorate level nurse anesthesia training model. So they're moving from them. I believe that the ANA has moved from a master's training to now I believe all of their training programs are now doctorate or at least connected to a DNP program. So now that I've talked about our DMPH programs, I want to talk to you and start the conversation about the HRSA scholarship and loan repayment programs that are that is beneficial information for those that are part of the DMPs of Color Association. So I start first with our National Health Service Corps program, which is one of our flagship programs at HRSA. The HRSA's National Health Service Corps and Nurse Corps are two critical programs offering workforce solutions to primary healthcare challenges in rural and underserved communities. My Deputy Director, Tara Spencer, will talk to you about the Nurse Corps, but I'll start that introduction about NHSC. So NHSC has a couple of programs. One of the programs that does benefit nurses, especially DMPs or nurse clinicians, is the NHSC Loan Repayment Program. NHSC helps remove financial barriers for primary care clinicians, enabling them to provide care in high-need areas. Portions of service obligation can be fulfilled by teaching, flexible service obligations, increasing access to primary care services to rural communities in need. What the NHSC does is they build healthy communities by providing financial awards to primary care providers committed to serving in the nation's high-need, rural, and tribal areas. And the NHSC incentivizes students and healthcare professionals to choose primary care, including many from minority or rural backgrounds who otherwise may have been prevented from serving in underserved communities because of financial barriers. And so what NHSC does, like I said earlier, is that NHSC has awarded scholarships and loan repayments to healthcare providers dedicated to working in areas with limited access to care for nearly 50 years. I think we've actually reached the 50-year mark for NHSC being in existence. So for the loan repayment program, which is one of those that nurses qualify for under the NHSC, the individuals can receive up to $50,000 of loan repayment for 2 years of service. This program offers fully trained primary care clinicians, and in the next slide, I'll show you who those are. A loan repayment in exchange for service in an area of greatest need called a health professional shortage area. And so this map shows you what that looks like across the country. And what you need to know that with continued service providers may be able to pay off all their student loan debt. It's also important to note that applicants working at NHSC approved sites with higher HRSA scores are given priority. And the HRSA scores range from 0 to 26. So these are the eligibility for NHSC. Of importance is I want to note that nurse practitioners who are primary care nurse practitioners, certified nurse midwives, and psychiatric nurse specialists are qualified for NHSC loan repayment. I'm saying that because in the past, this was not the case. It was mostly physicians, but they've expanded this program to include nurses as well. This is another NHSC program that nurses qualify for. Is the Substance Use Disorder Workforce Loan Repayment Program. The program aims to expand and improve access to quality opioid and substance use disorder treatment in underserved areas nationwide. Recipients for this loan repayment program can be awarded up to $75,000 for a 3-year service commitment. They must be trained and licensed to provide SUD at NHSC-approved SUD treatment facilities. And this is as part of HHS and HRSA's swift response to the opioid epidemic. And this is basically one of those programs that was developed to address the issue. For eligibility, I want to point out that not only are MPs and CNMs eligible for this program, registered nurses are also eligible. But you have to remember that priority is given to applicants who have a license or certification in substance use disorder interventions, such as a master's level substance use disorder counselors. Also, they look at priority for those with Data 2000 waivers or currently providing care in opioid treatment programs. The next NHSE program I want to talk about is the Rural Community Loan Repayment Program. This program expands and improves access to quality opioid and substance use disorder treatment in rural areas. The program awards up to $100,000 to individuals for 3-year service commitments, and they must be trained and licensed to provide SUD treatment at NHE-approved rural SUD treatment sites. And so again, just like the SUD program, this one, NPs, CNMs, as well as registered nurses and nurse anesthetists are eligible for this program. Priority is given to those applicants with Data 2000 waiver again, currently providing care in an opioid treatment program at an NHSE approved site, or who have a license or certification in substance use disorder interventions, such as those SUD counselors. There's another NHSE program that I will end with. It's the Students to Service Loan Repayment Program. Through this program, the NHSE offers up to $120,000 in tax-free loan repayment for 3 years of full-time service or 6 years of half-time service. Loan repayment begins during residency. With continuous service, eligible providers may be able to pay off all their student loans. The initial award amounts are up to $120,000 for 3 years full-time, or up to $120,000 for 6 years half-time. And to be NPs and CNMs are also eligible for this program. And next up is Tara Spencer to talk about the Nurse Corps program.
Absolutely. And I'll be quick. I know we're running very low on time. Good evening, everyone. Thank you for your time. So the Nurse Corps program helps to alleviate the critical shortage of nurses in high need, high demand areas across the U.S. and its territories. Currently, there are more than 3,300 Nurse Corps participants that are serving in over 2,500 sites. Our Nurse Corps participants provide care to more than 3.5 million patients annually in urban, rural, and tribal areas. And about 20% of them work at community health centers or community health center lookalikes. So the Nurse Corps has 2 separate programs. There's a loan repayment program for nurses who work in facilities experiencing a critical shortage of nurses. There's also a loan repayment for nurse faculty and scholarships to students who are enrolled or accepted into schools of nursing for enrollment. Next slide, Adanna. And we're really low on time. So for the Nurse Corps Scholarship Program, you are eligible for a Nurse Corps Scholarship Program if you are a student that is accepted or enrolled into a diploma, associate, baccalaureate, or graduate degree nursing program. And in exchange, you must work at an eligible facility that is considered a CSF or critical shortage facility upon graduation. Next slide, please. So the Nurse Corps Scholarship Program covers the following costs: tuition, eligible fees, annual payments for other reasonable costs such as books, clinical supplies, instruments, uniforms, etc., as well as a monthly stipend. So the Nurse Corps Scholarship Program application cycle will actually open on March 5th. So if you are interested, or if you know any individuals that are looking to go to nursing school or in nursing school, let them know that that application cycle will open soon. Next slide, please. So there's also the Nurse Corps Loan Repayment Program. So that program offers loan repayment to nurses who work in health centers, rural health centers, hospitals, other facilities experiencing a critical shortage of nurses, and also to faculty who are full-time that teaches in eligible public and private schools of nursing. Next slide, please. So you're eligible for loan repayment if you're a licensed registered nurse, if you're an APRN, such as a nurse practitioner, or, like I said, nurse faculty with qualifying nursing debt. If you received your degree from an accredited school of nursing in a U.S. state or territory, and you work full-time at a CSF in a high-need area for our RNs and APRNs, or an accredited school of nursing for our nursing faculty. Next slide, please. If awarded, you can pay off up to 85% of your nursing education debt. The program will award 60% of your unpaid nursing student loans in exchange for 2 years of service. And if you commit to a 3rd year, we will pay an additional 25% of your original balance. The Nurse Corps Loan Repayment Program cycle is actually open right now, and that cycle closes on March 7th at 7:30 p.m. Eastern Time. Next slide, please. So here's some ways that we were thinking about partnerships. How can DMPs of color and HRSA work together collaboratively? I think, of course, platforms like this are very valuable where we can share information back and forth, but as well as working together on other speaking engagements, being able to share information about our programs, being able to share information about our notices of funding opportunity, and also having you guys partner with some of our working nursing workforce development programs, as well as attending and participating in some technical assistance activities, webinars, things of that nature. Next slide. Sorry, I'm talking so fast. But also the role of partnerships. All of our workforce development programs, we have a triad of partnerships where all of them have to have an academic, practice, and community partnership. DMPs of Color, being a nonprofit organization, will be perfect to be community partners for our grant-funded programs. Also, as an applicant for some of our programs, a lot of our nursing workforce development programs are open to nonprofit organizations. So you as an eligible entity could actually come in for some of our nursing workforce development program funding and be able to help us move the needle forward in the nursing workforce. Next slide, please. We have a National Advisory Council on Nursing Education and Practice. So this is a regulatory, statutorily supported advisory council that is open to any nurse in the US, whether you're a student, whether you're practicing RN, APRN, faculty member, and this council advises the Secretary of the US Department of Health and Human Services, as well as Congress, on policy-related issues to all of our Title VIII programs. As a committee member, there's a 3-year term. There are 4 mandatory meetings per year. Most of them are virtual. There is 1 usually per year that is in person in Rockville, Maryland. The nomination period is open, so you can nominate yourself, nominate your peers at any point of time. And if you do self-nominate or nominate a peer and they are not selected, the application stays on file for 3 years. Also, as members of DMPs of Color, this is an open meeting. So anytime there is an advisory council meeting, they are open to the public. You can join, whether it's on Zoom, whether it's in person. And there's also a dedicated time slot for public comment. So if there are things that you are hearing in the meeting and you would like to speak, or if there are things that are going on in the field or issues that you feel like can be addressed by the council, and recommend, and recommend it to Congress and the Secretary, it's a perfect opportunity to be involved at the federal level. Next slide, please. And then become a grant reviewer. I can't emphasize enough how many reviewers we need for our grant programs. All of our programs are competitive, so we need reviewers for all of our programs. The reviewers review the eligible applications against the review criteria that we put in the notices of funding opportunity. You're able to rate and input your scores and then discuss your scores on a panel with reviewers that are on your panel. How are our reviewers selected? Based on your knowledge, education, experience. We select them based off of the criterion that we put in our notices of funding opportunity. So of course, all of you are nurses. We have nursing programs, so that would be a criteria that would allow you to be a reviewer. But what are the benefits? You get to learn about the grant making process. This allows you to see how applications are reviewed, how they're scored, how we look at the review criterion and score it against an application. It gives you insight to how some grant applications are written, the ones that are funded versus the ones that are not recommended for funding. So it's a great tool, whether you're interested in grant funding, interested in grant writing, or as an organization interested in coming in for funding. Being a reviewer is, I think, a great asset and a skill set to have. You get to meet and work with others, and you earn an honorarium as a non-federal participant. Next slide. So here are 2 QR codes, one to learn more about being a grant reviewer, the other one to actually register to become a grant reviewer in our reviewer recruitment module. So I think these slides will be available to you, but you can reach out to Adanna and I if you have any questions about being a reviewer, about any of our programs. And I think I made it in enough time. Is this the last slide? I did
Yes,
it.
it is.
Okay. All right. Thank you so much for your time.
Okay, good evening, everyone, and thank you to all of our presenters. A wonderful job. So we do have time for a few questions. Let me see. First of all, I think this will be to Dr. Brunner Hill. Will this presentation be available?
So, good evening. Yes, I will get the slides from the presenters with their permission and send it to those who are registered for this webinar.
Okay, thank you. And we also have a question from Dr. Marshall Blue. This is for Ms. Spencer. Will the individual go to the HRSA for the link to the loan repayment program? How would they access the link?
Yeah, you can go to the link. I can actually put it in the chat right now, so that way you can have direct access to it.
Okay, thank you, thank you. I know Dr. Cheatham responded to Dr. Blue, but I'm not sure if everyone saw the responses. But this is from Dr. Blue. He may have missed something, but who funded the lactation program? Dr. Cheatham?
Yes, so the lactation program didn't cost anything to fund. I actually created this lactation course from scratch using the recommendations of the CDC, peer-reviewed articles. So all that was from scratch. Also, the materials that was used, such as tables, chairs, curtains, was all provided by the YMCA, and it came from supplies that they already had. We also provided hands-on lactation training using actual dolls to practice the different positioning techniques, which is one of the things that mothers have the most trouble with when breastfeeding. And so we use the CPR dolls that the YMCA also already had. So really there was no cost because our population, the members are already, the YMCA members already have memberships, and then it was free to people of the community to come into the class. So there was really no cost there. One of the things that did do to invest in this project and to invest in, I guess, my journey as a lactation consultant and to continue to represent them is that they paid for part one of the IBCLC lactation certification class. That way it further enhances my knowledge to speak on behalf of lactation. And then as far as the question, are we going to implement it into regular program? That's still under discussion. We're still trying to get that coordinated. And one of the other things that we have discussed and was recommended is to make this open to a nurse-led educational program, meeting other like BSN students, ABSN students, nurse practitioner students, can all teach this class with the local YMCA. So the university has actually established a contract with the YMCA. So we're working on that. And then hopefully in the future we can duplicate and expand to other YMCAs.
Okay, thank you, Dr. Cheatham.
Yeah.
Let's see if we have any others. We do have a question for either Dr. Agbo or from Ms. Spencer. How does HRSA support novice grant reviewers?
You want to take that, Adanna, or you want me to take it?
I can take it. So HRSA's Office of Federal Assistance Management is in charge of working with reviewers to prep them and get them ready to do reviews, to complete reviews or conduct reviews or execute reviews. And through that office, there is a division of an institutional review. And what they do is when they have new reviewers, they have actual training for them, that they walk them through what it is like to review and what they need to do. And when that reviewer is now assigned to a panel to conduct review, the program staff is also then responsible for having a call to explain that program, explain what's expected, and explain everything that they need to know to review that the applications. In addition to that, the new reviewers are also paired in the same panel with experienced reviewers so that they can hear and see how other people are reviewing, provide support and help them. So we actually identify who was a new reviewer in a panel so that they can receive support from not only the OFAM's office, the DIR office, as well as other experienced reviewers, as well as the chair of that panel. So there are different things that HRSA does to support new reviewers and making sure that they're successful.
Okay, thank you, Dr. Agbo. I do not see any other questions in the chat. Only great job. And again, we want to thank our supporters and our presenters. So at this time, I want to turn it back over to Dr. Brunner-Hill.
Acknowledge our programming committee and thank everyone on the programming committee. Myself, Dr. Kingsley, Dr. Linton, Dr. Blue, who's providing us this great technical support. Thank you for that. Dr. Conyers, Dr. Cole, and Dr. Rose. Here's a list of our upcoming events. And there's also the QR code if you want to register for any of those events. We are accepting members, and so there's four different types of membership. The DNP professional, nursing student, nursing professional, and affiliate non-nursing professional. Once again, there's the QR code for you to join DNPs of color.
Hi, this is Dr. Patrice Kiesling. The programming committee, Dr. McCain and Dr. McCamey, our president, founder, and CEO, would like to thank you for attending our first annual Doc Talks webinar.
And as I stated earlier, you see our list of events. Hopefully we'll see you in the near future at one of those events. And just remember, we are accepting new members. So we look forward to you joining our membership as well. Thank you, everyone, and have a great evening.
Thank you.
Thank you.
And if I can have just the programming committee stay on for a brief moment, please.